Hey everyone, we're going to go ahead and get started. I am Carissa Hickok, and I am the National Manager of Professional Education and Outreach for the American Liver Foundation. And welcome to our first Liver Health Project ECHO meeting. We're so excited everyone is here. This was created to bring treatment and prevention best practices for non-alcoholic fatty liver disease, NAFLD, now known as metabolic dysfunction associated steatotic liver disease, to non-liver experts. Over the next few months, we will do a deep dive into the different topics we have presented and really trying to equip healthcare providers with the necessary skills to treat and prevent NAFLD along with patients. Participants will gain support and mentorship, enhance their skills, and connect with leaders in the field, all at no cost to you. So first, we would love to know who we have all on here today. If you want to put in the chat, just to introduce yourself, about your name, your location, your organization, and any other information you'd like to share, that would be great for us and our presenters so they know who they're speaking to. So again, just drop that in the chat when you're able. And I'd like to introduce our first speaker today, and that is Dr. Anita Krishnarao. She is a transplant hepatologist, UMass Medical Center in Worcester, Massachusetts. She received her medical degree at Brown University and Master's in Public Health degree at Columbia University. She went on to complete her internal medicine residency training at Tufts Medical Center, then completed her GI and transplant hepatology fellowships at Leahy Medical Center. She's been on faculty with UMass since 2020, and she is currently the Associate Program Director of the GI Fellowship. Her clinical interests include metabolic syndrome associated liver disease and liver transplant. So thank you and welcome, and we will turn control over the slides to you.
Great. So thanks, everyone. Thanks to the American Liver Foundation and Project ECHO for having me. I'm excited to chat with you all about MASLD, and this will just be a brief review of MASLD and MASH, and happy to take any questions along the way. All right, I do have a couple disclosures listed here, but neither of which will impact the session today. And over the next, 20, 30 minutes or so, I'm hoping to review the following. So first off, I'll review the definitions of metabolic dysfunction-associated steatotic liver disease, some risk factors associated with this disease, review the increasing prevalence of this disease state, go through the natural history, and then the overall prognosis for patients with MASH and MASLD. All right, so there is a separate session, I believe, that's reviewing specifically the terminology for the change in nomenclature for MASH and MASLD. So I don't want to spend too much time on that right now, but just so we're all on the same page in terms of what terms I'm using and what we're calling it. So the old terminologies were NAFLD and NASH, but now we're switching over to MASLD and MASH. So MASLD being metabolic dysfunction associated steatotic liver disease, with a little bit of a mouthful, and then MASH is the old NASH. So MASH being metabolic dysfunction associated steatohepatitis. There's also an entity called that we used to refer to as NASH-ASH, which was a combination of liver disease from metabolic syndrome and alcohol-related inflammation. And so now we're calling that MASLD, which is exactly that, metabolic syndrome and alcohol-related liver disease. All right. So what is MASLD? So MASLD is this umbrella term that we use for patients who we colloquially say have fatty liver disease. And so it does require basically evaluation of three things. So first off, the patient should have some degree of increased fat in the liver, either demonstrated on a liver biopsy or some sort of imaging of the liver. Next, there should be an evaluation of the presence of cardiometabolic risk factors, which I'll go through shortly here. And then you also want to make sure you're evaluating for other causes of increased fat in the liver. So not every patient with increased fat in the liver has MASLD. So as I mentioned, MASLD is this umbrella term. It encompasses both patients who just have simple steatosis in the liver, so steatosis being just fat in the liver. And someone's considered as having increased fat in the liver if they have over 5% of their liver tissue is fat. So some patients may just have that, just steatosis, and they don't necessarily have associated injury as a result of having increased fat in the liver. And patients that don't have associated injury associated with this fat actually have a decreased risk of developing advanced liver disease in the future. And that's in contrast to what we call steatohepatitis. So this is what we refer to as MASH. It still falls under that umbrella term of MASLD, but more specifically, it's patients who have not only increased fat in the liver, so again, greater than 5% fat in the liver, but in addition to that, they have an increased, they have associated inflammation and injury associated with that increased fat. And those are the patients that are at risk of developing fibrosis or scar tissue in the liver, more so than someone who just has simple steatosis. So basically, if you have a patient who has advanced liver disease and you're attributing it to MASH or MASLD, by definition, they really have MASH, because in order to develop scar tissue, at some point you have to have had inflammation associated with the increased fat in the liver. And so that is MASH and no longer just simple steatosis. So anybody who has cirrhosis as a result of this liver disease has had MASH cirrhosis. And so really the gold standard way of differentiating, does someone just have increased fat or do they have fat and inflammation, is with a liver biopsy. And I'll go through in a little bit, but we don't always necessarily have to do that, but that's kind of the gold standard way of differentiating the two. So if you do a biopsy on the liver, this is basically what you'll see. So on the left is a patient who has just simple steatosis. So they don't have any associated inflammatory cells on the biopsy. You just see these fat droplets on low and high power field, and that's on the left. Now, if you have MASH or steatohepatitis, you not only have those fat globules, but you see these little purple dots. Those are the inflammatory cells. So patients who have fat that is leading to inflammation, that's what they're going to look like on biopsy. And interestingly, we a lot of times use liver tests as a surrogate for which patients are higher risk or which patients have inflammation in the liver as a result of increased fat in the liver. But that may not always be accurate. So there was an old study done in 2008 that actually looked at patients who had this disease state that we called, NAFLD at the time. And, actually biopsy patients who had normal liver tests, specifically a normal ALT level. And actually up to 50% of those patients had both fat and inflammation as a result of fatty liver disease. So just because somebody has normal liver tests doesn't necessarily mean that they don't have inflammation related to the increased fat or MASH. So just a word of caution when you're seeing these patients if they have normal liver profiles. So the second part of defining MASLD or MASH is doing an assessment of cardiometabolic risk factors. So really the patient should be at increased risk of metabolic syndrome or have these risk factors to really be considered for this disease. So the two big risk factors for MASH or MASLD are obesity and type 2 diabetes. Over 50% of patients will have at least one of these risk factors. The other big risk factor is what's called metabolic syndrome. So metabolic syndrome is defined as having three of the following. So increased central adiposity, so increased waist circumference or carrying fat in the midsection, an increased triglyceride level, lower HDL levels, high blood pressure, and an elevated fasting serum glucose, so diabetes. And so, again, when you're evaluating someone who has increased fat in the liver, you're thinking this they may have MASH or MASLD, you want to be thinking about these risk factors. And if they're present, then, the likelihood is higher. I just want to mention there is an entity called non-obese or lean MASLD. So not everybody with who has fatty liver disease is necessarily overweight. Some of the reasons for this is, by the time you're seeing them, they've already had a weight loss. They may not meet BMI criteria cutoffs for being overweight. There's also different BMI cutoffs for different ethnic populations. So for Asians, actually the BMI cutoff for being overweight is over 23. And as you can see, the list of risk factors for metabolic syndrome, not all of them are weight related. So there's only one that's really weight related. The rest, you can easily have without necessarily being overweight. So patients with type 2 diabetes who are not overweight are still at risk of this disease. And also patients meeting metabolic syndrome without being overweight, obviously, are still at risk for this disease as well. Other risk factors associated with MASH and MASLD. So with a lot of diseases, there's an increased prevalence of MASH and MASLD as you get older. There's an increased risk of fibrosis or scar tissue associated with this disease as you get older. There tends to be a greater prevalence in males compared to females. Interestingly, there's also certain ethnic groups that tend to be at higher risk for developing MASH and MASLD, even when you're controlling for all the other risk factors. So Hispanic populations tend to have higher rates of MASH and MASLD, even when controlling for similar rates of diabetes. Same thing, and in contrast, African Americans actually tend to have lower risk for MASH and MASLD, again, similarly when you control for other risk factors, which not completely defined why that is. There also are some genetic polymorphisms that are being looked at as carrying higher or lower risk for MASH and MASLD. And actually that first one listed there, the PNPLA gene mutation, has actually been associated with not only having an increased risk of developing MASH MASLD, but also worse prognosis. So more work to be done on that. So the last part of evaluating someone who potentially has MASH and MASLD is evaluating for other causes of increased fat and increased fat inflammation in the liver. So there's a variety of things that a variety of other entities that can cause increased fat and inflammation in the liver. And the big two are heavy alcohol consumption as well as viral hepatitis. So both of those things can not only increase the amount of steatosis or fat in the liver, but can lead to steatohepatitis. So it is important when you're seeing these patients to evaluate for that, to get that social history. So there's an increased risk of steatohepatitis for males who drink greater than 21 drinks per week, and for females over 14 drinks per week. Also, it's important to evaluate for viral hepatitis, particularly hepatitis C virus can cause increased fat and inflammation in the liver, and sometimes can cloud the picture when you're evaluating someone for MASH and MASLD. There's also a variety of medications. Some of the more common ones are listed here that cause increased fat in the liver. So again, it is important to do this initial history taking when you're seeing a patient who may be carrying the diagnosis of MASH and MASLD. And there's a variety of other lesser common liver diseases that can cause increased fat in the liver, and they're listed here. So things like iron overload and copper overload. Thyroid disease can independently cause increased fat in the liver, celiac disease as well, and then some other liver diseases like autoimmune hepatitis, alpha-1 antitrypsin deficiency, and also patients on TPN have an increased risk of fat in the livers. So just things to keep in mind as you're ruling out other things when you're seeing someone with increased fat in the liver. So this is my kind of approach to someone who sees me in clinic or was referred for consideration of fatty liver disease, MASH or MASLD. So if someone just has increased fat in the liver on some sort of, on either a biopsy or some sort of imaging, the box on the left is kind of the workup I go through in addition to getting a social history. So you want to check for, viral hepatitis. You want to make sure they don't have iron or copper overload, check thyroid studies. The next one is for celiac disease, and then kind of rarer causes, as I mentioned, alpha-1 antitrypsin. So if somebody has, on the box on the right is for somebody who has, either liver test elevation or evidence of more advanced liver disease and fat in the liver. So I'm going to do all the things in the box on the left, in addition to some other studies that can cause liver test elevation, like the autoimmune studies, like the ANA, ASMA, AMA. So this is just kind of the kind of comprehensive list of things I check when I'm seeing someone for, as a referral for potential MASH. And when you're seeing these patients, there's kind of a wide variety of a wide range of how these patients can present. I'd say the vast majority of patients present in a pretty, asymptomatic way. Most patients, unless they have more advanced forms of liver disease, really aren't going to have any symptoms. Sometimes they may have evidence of hepatomegaly or enlarged liver on imaging that they've had previously that was what ultimately showed the presence of increased fat in the liver. And as I mentioned, if they have more advanced forms of liver disease, then you potentially will see, features of decompensated cirrhosis, like volume overload or jaundice. But again, that's not going to be present in the majority of patients you're seeing for this. In terms of blood work, I mentioned that patients could, can easily have, and a lot of patients do have normal liver tests. So the presence or absence of liver test elevation doesn't necessarily, clinch the diagnosis. Typically, if patients do have liver test elevation associated with MASH and MASLD, it's pretty mild. Typically the ALT is slightly higher than the ALT, but usually the AST and ALT are going to be less than 2 times the upper limit of normal for these ranges. And a lot of patients, when we do the workup for other forms of liver disease, will end up having an elevated ferritin, just by nature of it being an acute phase reactant. It's very common to see a ferritin elevation in patients who have underlying MASH. And a lot of these patients, when they come to see me, they've already had evidence of increased fat in the liver on some sort of imaging that has been done previously. So you'll see increased echogenicity on an ultrasound. On CT, you'll see that the liver looks like it's has decreased attenuation. And on MRI, they'll have increased fat signals. So, for example, here, picture a CAT scan. Basically, what the trick is, you compare the liver to the spleen. If the liver is darker than the spleen, you see that's decreased attenuation. So that's a sign that they have increased fat in the liver. So that's a marker of potentially having an underlying MASH and MASLD. And then, as I mentioned earlier, a lot of these patients aren't biopsied. So it is hard sometimes to figure out, do they have just simple steatosis or do they have, increased fat in the liver with associated inflammation? And, this is kind of a decision that we're making more on the, hepatology side, but, there's a few things that I keep in mind when I think about, does someone need a liver biopsy to diagnose this? Because there are nice non-invasive ways to assess the degree of fat in the liver and fibrosis in the liver. And that's going to be in a different session, just kind of the workup and management of this disease, but I won't go too much into that. But things I think about when I'm thinking about, is this patient truly have the diagnosis of MASH MASLD, is if someone has kind of an atypical presentation, they have increased fat in the liver, they have some mild liver tests, but they don't have those risk factors that we went through. They're not obese, they don't have type 2 diabetes, but they maybe have a couple risk factors for metabolic syndrome. That might be someone you consider a biopsy for. If you're really trying to figure out the stage of fibrosis that they have, and for some reason they're not a candidate for non-invasive testing, you could consider a biopsy. We in our institution, we are involved in some clinical trials for some of the medications coming down the pipeline for MASH and MASLD. So some of those studies do require a biopsy. Or, if you're doing an evaluation for other forms of liver disease, MASH plus maybe autoimmune liver disease or drug-induced liver injury, and you can't figure out what's what, sometimes a liver biopsy is helpful in those scenarios to figure out, is this all MASH or is it all, something else? But basically, my mantra is, if it's going to change management, then I would proceed with more invasive evaluations such as liver biopsy. And so why are we talking about this? So when you go through that exercise, someone has increased fat in the liver, you've ruled out other causes of increased fat in the liver, and patients have, and someone has increased cardiometabolic risk, a lot of patients meet that criteria. And so as the prevalence of diabetes and obesity has risen, so has the prevalence of MASLD. And so this is a global view of patients being diagnosed with MASLD. And some of these may be underestimates. It's hard to fully gauge, the true prevalence of this disease, because not everybody's seeking medical care. But it's thought that in North America and the US, the estimate is anywhere from 20 to 40% of patients have MASLD. Now, this is MASLD. This is just presence of steatosis with risk factors for metabolic syndrome, not necessarily steatohepatitis. And the next, I'm actually going to go back here, and so you can see in some of the countries that have lower percentages, it may not, again, may just be an underestimate because those patients aren't necessarily coming to seek medical care. And the prevalence, as I'll go through in a couple slides here, the prevalence of MASH, or steatohepatitis, is much lower. But these are all patients who are at risk for developing more advanced forms of liver disease. So this is basically an outline of the natural history of this disease. So, you start out with healthy liver, right? And so, and then patients develop increased fat in the liver or steatosis. So that's the map I was just showing you. So that group of patients that we use this umbrella term MASLD can be up to about 40% of the population. And that kind of tracks along with the increasing prevalence of diabetes and obesity. And the big place where we risk stratify is, whether those patients have fat and inflammation or just fat in the liver. And so it's a lot less is known about what the risk factors are from going from, just simple steatosis to having steatosis plus inflammation. And that's really where a lot of the impacts to prognosis occur. When you have steatosis and inflammation, that's where you're at where you're at increased risk of developing more advanced forms of liver disease, and you have increased risk of, developing liver cancer, which I'll talk about shortly. And so when we talk about MASH or steatohepatitis with these increased risks of things that impact someone's overall mortality, the prevalence of this is much lower. So about 5 to 10% of the patients with MASLD will go on to develop MASH. And this is, in general, all comers with MASH and MASLD are listed here. So there's been a variety of prevalence studies that have looked at patients just with MASH, this kind of higher risk phenotype of this disease. And you can see in the U.S. the estimates are anywhere from 2.5% to 5%, which depicted in the yellow bars there. So still, not quite as impressive as the numbers for just having, for MASLD, but pretty impactful. I mean, 5 out of every 100 patients can have this, kind of higher risk phenotype of fatty liver disease. So definitely is a concern, and why we're all here today. So as I showed you, this is the natural history, and it's really at this stage where patients develop fat in the liver and inflammation that you have increased risk for things like cirrhosis. So when you have inflammation in the liver test elevation, and if you do a biopsy, there's inflammation there, that's where you develop the risk of having progressive fibrosis, and then down the line cirrhosis as a result of fatty liver disease. And that's about 1 to 2% of this population. And it's thought that patients progress their fibrosis stage, so stages from 0 to 4, progress in their fibrosis stage about every couple of years. So this is not something that's going to happen overnight. It's not going to happen, in a year, but over a course of several years, you can develop advanced liver disease. And as we all know, that's associated with increased risk of liver-related complications like variceal bleeding events, volume overload, jaundice, and then also liver cancer or hepatocellular carcinoma. So interestingly, with MASH, and sorry for the old terminology on this slide, the patients don't necessarily need to have advanced scar tissue or advanced fibrosis in order for them to develop hepatocellular carcinoma. So like other liver diseases like hepatitis C, there's an independent risk of developing liver cancer in patients who have MASH but don't necessarily have cirrhosis. So that's concerning. It's scary. Obviously this will be a minority of patients, but something to be aware of when you're seeing these patients. So it's really, again, this phenotype of increased fat in the liver with inflammation that bodes a worse prognosis for these patients. And as I mentioned, there is an independent risk of developing liver cancer in patients who have steatohepatitis, but it's actually not in the guidelines in the American ASLD, the American Liver Disease Guidelines, or the European guidelines to screen patients who have MASH for liver cancer, because the prevalence is low. The incidence is reported as less than 1%. That's probably a little bit on the low side, just based on lack of reporting of these events. But it's not because the risk isn't there. It's because the cost effectiveness of screening patients who don't have cirrhosis for liver cancer is on the low side. But given how many patients we have that have MASH and MASLD, that we do see a fair amount of patients who do have develop liver cancer, even if they don't have cirrhosis. And I will say that if I have a patient who has more advanced forms of fibrosis, even if they don't have cirrhosis, I am screening that patient for liver cancer. And then I just wanted to put this in, kind of the tracking along with the increased prevalence of this disease and increased rates of MASH-related cirrhosis. There's an increased rate of patients who have MASH cirrhosis who are undergoing liver transplant. So you can see that over the years, the trajectories of some of these diseases and patients going to transplant is really changed. So the landscape of transplant is very different now than it was 20 years ago. And you can see that with all the new and wonderful hepatitis C medications, that the transplant rates for patients who have hepatitis C related liver disease is much lower than it was 20 years ago, whereas MASH is now the second most common reason to develop advanced liver disease and go on to need liver transplantation. And it's actually the leading indication for liver transplantation in females. So again, just kind of emphasizing the increased impact this disease is having on medicine and hepatology. And interestingly, when we talk about overall prognosis for patients with MASH and MASLD, the number one cause of death for patients with MASH-related liver disease is not actually liver-related. It's actually cardiovascular disease. And this is not surprising, since we know that the risk factors for developing this disease are obesity and type 2 diabetes. And so those are the big risk factors for things like, heart disease and stroke. And so the leading cause of death in patients with MASLD is really cardiovascular disease. And then after that, it's actually liver-related mortality. So things like more advanced forms of liver disease and the complications that come with that, and liver-related cancers. And then third on this list is cancer-related mortality. So we know that obesity is associated with increased risk of certain cancers. And so again, that kind of makes sense that it's on the list of causes of mortality for patients with fatty liver disease. And again, just to reemphasize, that it's really the patients who have fat and inflammation in the liver that have these higher rates of liver cancer and higher rates of progression to advanced forms of liver disease. So that's really all I have for today. Today was really meant to be just kind of a brief overview of the disease. And the things to really take away from this presentation is that, not everybody with increased fat in the liver has MASH or MASLD. You want to make sure that they have risk factors for cardiometabolic syndrome, and that you're evaluating for other reasons for increased fat in the liver before labeling them with MASH or MASLD. And then the overall prognosis of this disease for patients is impacted by the presence of not only fat, but increased inflammation associated with that fat, or what we call MASH. And that's what leads to development of cirrhosis and increases someone's risk of liver-related cancers. So happy to take any questions. Those are the references I used. And thanks again for having me. Hopefully this was helpful.
So yes, you can go ahead and unmute yourself and ask any questions, or you can drop them in the chat too. We'll just pause for a minute. And you can also, we'll hopefully have some time at the end. You can also ask some more questions too. So thank you so much for that wonderful presentation. Next, we are going to share a video by Dr. Rotonya, the Division Head of Gastroenterology at the University of Washington, about the NAFLD name change. We are only going to show a little bit of it, but you can find the whole video on our YouTube channel.
Hi, I'm Dr. Rotonya Carr. I am a board member of the American Liver Foundation. I'm also the division head of gastroenterology at the University of Washington and a hepatologist. The latest update is that the old name of non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis, NASH, is no longer. We have a new name, a new nomenclature, as we call it. And the new name is metabolic dysfunction associated steatotic liver disease, or MASLD. And then for people who have more advanced forms of that liver disease, we call it metabolic dysfunction associated steatohepatitis, or MASH. So we used to have NASH, now we have MASH. The whole world got together to think about whether the old name of NAFLD and NASH needed to change. We had patients come together through various patient organizations. For example, the American Liver Foundation participated in this process. We had doctors and scientists in many countries around the world coming together over several years, really talking about this challenge of the old name. We tried to answer, if we wanted to keep the old name at all. If we didn't want to keep the old name, what is important about making sure we had in place for the new name? And finally, if we were going to change the name, what should that name be?
Okay, so that's just a brief little snippet of that video. And again, you can watch that on ALF's YouTube channel. So moving on to the next part of our presentation today, I would like to introduce Dr. Rockford G. Yapp. Dr. Yapp is a board certified in internal medicine and gastroenterology and has performed over 20,000 endoscopic procedures in his career. His training includes medical school at the University of Nebraska Medical Center with training at Cornell University, Cook County Hospital, Shiprock, New Mexico, and Nairobi, Kenya. He completed his residency at Northwestern University in Chicago, then went to Yale for his GI and hepatology fellowship. Dr. Yapp also earned his master's in public health and medical research and has worked as an attending at Yale. So I will turn it over to you.
Wow. Thank you, Sydney. You sound like my mother. First of all, I want to thank you, first of all, for the honor of being among this group of physicians on this conference and the ones we're going to have in the future. I just want to say the ALF is just a outstanding organization that I'm very proud to be part of. And I want to compliment Anita. That was just an outstanding presentation. I don't know if I can bring up my slides. I'm just going to say I have associations. I'm an IAD board speaker for Gilead, AbbVie, Medical Exact Science. None of these have any impact on my talk tonight. As mentioned by Sydney, I'm also a former board member of the American Liver Foundation on their medical advisory committee, and also I'm on the ASLD policy committee. So, as I said, honored to be here. And so what I was asked to do is just bring up some cases. I think everyone on this call who treats patients, if you just treat a few patients a day, every one of you have patients with this disease. As Anita so pointed out, this is a huge medical problem, and we're just starting to understand the coming, some people say, the tsunami of patients that we're all going to have to treat and be aware of. I recently gave a talk to a group of family practice physicians, and I told them whether they like it or not, family practitioners are going to have to become hepatologists, and I still believe that. I think all of us are going to have a level of expertise to help our patients really understand what's going on. So I just have a couple cases that sort of maybe we can talk about that help elucidate some of the things that all of you will face. I'm going to go back one more. I just want to look, if you look at the previous slide, this is just, again, I'm a liver lover, as I said before. I'm also a big supporter of the American Liver Foundation. It is an outstanding organization. I'm proud to be been on the board of the past. I'm also proud of the things they continue to do in education, not only among physicians, but also the advocacy they do for patients. So I really encourage you not only to go on their website, but find ways that you can get involved with their organization, their mission. I encourage you to donate. If you can't donate, I encourage you to volunteer. The ALF has a role for everyone who wants to help people and family members with liver disease. So the next slide, I guess am I working? It's not working. So Sydney, if you just go to the next slide, that would be great. So, as I said, I have three quick case presentations. Again, all of you have seen, if you treat patients, you've seen someone like this, a female who has a long history of being overweight, has metabolic syndrome-related complications. She's currently on medications. She's recently gained weight. Interesting, she has a history of a motor vehicle accident in 1986 where she had a blood transfusion. She has her physical exam is known for having a BMI of 35. You can see her liver function tests are mildly abnormal, but not terrible. She has a fasting insulin and fasting glucose are a little bit high, and you can see her HOMA IR score is 6.8, which is elevated. For those who don't know this is a test to really look for insulin resistance, which is an important risk factor for MASLD and MASH. The ultrasound shows fatty liver, as we discussed before. The ultrasound can be a preliminary tool, not what I call the best tool, but a tool. The fibrosis 4 index. This is a scale that all of us can use. You need to know the age, ALT, AST, and you can calculate this. And this really gives you an idea of how a crude idea. There's some variance about what their risk for fibrosis. And hers was elevated at 4.83. Go to the next slide, please. So really, this case brings up, this is a case that all of you will see someone like her or are very similar, and brings up the questions that many of you might have. What further testing is required? What are the risk factors for liver disease? What's the status of her liver right now? What further evaluation will you do? And really, what do you want to do? What are the risk factors for developing significant liver disease in the months and years to come? And what do you want to do as far as treating her going forward? So questions that you should be asking all these patients when they come to your office. The next slide, please. So I'm just going to bring this up. She had a fiber scan. I don't know if we talked about that. Ultrasound is an interesting test. It's not a very accurate test for helping us with determining the degree of fatty liver content. The FibroScan is an excellent test that's becoming more widely available. I don't think there's a liver center in the country that doesn't have a FibroScan. And so I strongly encourage you to have a connection to a physician or a hospital that has this. And her FibroScan shows that she has a CAP score of 305, which suggests she has significant fat content in her liver. And in conjunction with that, she has an elastography score of 14.8, which just puts her into the cirrhotic range. Now, interesting, Anita mentioned before, alcohol is one of the risk factors. I would say probably in patients with MASH and METAF, they have the most common risk factor, co-risk factor, is alcohol. And this person admits to having 2 to 4 alcoholic beverages a day. So she has multiple risk factors for metabolic syndrome. She has obesity. She has hypertension, high cholesterol, insulin resistance to diabetes. She also is a heavy drinker. We also want to know about her family history of liver disease. She's a postmenopausal woman, and these patients often have more of a problem. So this brings up these. We got an idea. This patient is deep into her liver disease. She has significant steatosis. She has advanced fibrosis and probably cirrhosis based on the FibroScan. And so we really need to know what interventions we need to do in this patient. Go to the next slide. So these are the questions that all of you will have to answer. Now, is this someone that you and your primary care center, do you want to refer to a hepatologist or a liver treatment center? Is this patient someone we should start HCC screening, as Anita talked about so eloquently? And but also important things to do for this patient, we need to assess for liver disease, as Anita mentioned. We absolutely have to address her alcohol use. This is definitely a cofactor in her advanced liver disease, and we have to address this in an urgent way. We tell all of our patients with significant fatty liver disease, cessation of alcohol is one of the first steps we do. We also talk about weight reductions. Now, weight reduction is a key cornerstone in treating this disease, this condition, as all of you know, and we now have more and more ways to approach this. Medications are becoming widely available with GLP-1 agonists, GIPs, and there are more and more coming every day. This is an effective treatment for the fatty liver component, the fat component. The overweight is not as good quite as addressing the fibrosis. And then there's a new medication, resmetirom, the Resdifra, which has just been approved a few months ago on the market, which is, I think, it was one of the biggest advances we've had in the treatment of liver disease since sofosbuvir over 10 years ago. So these are all things that we start looking at. I think the first step is, as a primary care physician in the community, really identifying these patients is the most important thing. How far along the road you go with helping with weight reduction, talking about treating their metabolic syndrome, those are all things that many primary care physicians have expertise in. But this patient is someone that I would say you have to go to someone with expertise like Anita to share responsibility giving this person. This person clearly is going a route where her liver disease is going to become more and more of a problem and become someone that I feel that we need to have a shared team approach in this patient. Go to the next slide, please. So then we have other patients, and this is maybe slightly more common patient, not quite as far down the road, but another patient with a history of high blood pressure and long-standing obesity is on several drugs for treating her metabolic syndrome, has been gaining weight over time, has a BMI of 42, quite a big person. You see her labs here. Also, her labs are somewhat abnormal as well. Now, this person is actually a little bit larger than the patient we saw before, and she also has, as given the variability, she has more abnormal liver function tests, but she also, her fibrosis score isn't quite as bad. She is, even though she definitely has some evidence of of liver disease, most likely based on this evaluation, she's not quite far advanced. Her FibroScan shows again she has significant liver disease with a CAP score 302, and her elastography score is 8.7, which puts her in a problem. So she's at risk. She's someone that needs your attention, but is also someone that isn't as far along down the road. And maybe a lot of this can be handled by the primary care physician, maybe some help with a gastroenterologist, hepatologist. But this person is someone that you can really make a difference by intervening now. I think with Anita's excellent presentation, you saw these patients are not, maybe not next month, maybe not even next year, but if nothing changes in this patient is going to be heading down the road, well, she'll need someone like Anita at Transplant Center. So she's at significant risk for liver disease progression without intervention. Go to the next slide. So what further testing will require? Talking about these are the same questions we asked before, essentially the same thing that we want to know and manage with help of these patients. Go to the next slide. So again, these are sort of the same questions I had before. Assessment of liver disease. We definitely, as Anita pointed out before, many of these patients have co-factors that can be a risk factor for this disease progressing. Obviously, we'll again talk about alcohol consumption. We'll go through the list of other risk factors, as Anita so wonderfully pointed out. There's a whole laundry list of tests that we do on these patients to make sure they don't have coexisting liver disease. As a person that runs a hepatitis C clinic, I make sure everyone remembers, so we screen all of our patients over 18 for hepatitis C. But we also want to look for hepatitis B. We want to look for other risk factors. We talked about alcoholism. We talked about before autoimmune factors. We talk about hemochromatosis. All those factors that we look at, we have to make sure we're not treating just one disease. And again, we also, in this patient, we once again talk about whether or not to put them on these new medications that are being so widely used. I think the GLP-1, the weight loss, the diabetes/weight loss medications are something that seriously have to be discussed with these patients. I also think that the medications that not only reduce weight but can also reduce fibrosis scores, as we found with Rezdiffra, are a significant advance that I really feel very strong about. I talk about statin use. Some of some may worry about statin use. You know that is that occasionally lifts a liver function test. I think we have through experience, and I think Anita will agree, statins are not contraindication to these patients. In fact, they may have some benefit. And I just put it on here. I'm being a coffee drinker. I think there is definitely some evidence that as Anita's drinking her coffee right now, there you go. So there's some evidence that coffee will actually help the patients with liver disease and maybe even help prevent cancer. Go to the next slide. there's the last one. This is the one that probably you'll see most often in your office. Again, a person who is a woman who's mildly obese, well-controlled blood pressure. She's mildly overweight, but needs to keep working on her weight. She's only 32, but she had some borderline liver function tests. This time they were in the normal range. She had a FIB-4 score of 1.28, fasting glucose a little bit high. Her HOMA-IR score is a little bit elevated, so she has some insulin resistance. And the fatty liver is shown on ultrasound. And we're a little worried about her being pre-diabetic or even starting to verge on diabetes. But interestingly, again, talking about the variability of this disease, she does have some fatty liver on her FibroScan, but the elastography is in the range that she's an F0 to F1. So this is the more common patient you'll see. I think of all the patients we worry about with fatty liver and with MASH or MASLD, this is probably the more common. And this is the patient that primary care, in my mind, can make the biggest difference. This patient doesn't need to see someone like me or Anita at this point for concerns about liver disease. It is possible, if nothing changes, she can have problems down the road. But this is where primary care physicians are so important. This intervening at this stage of this young woman's life, by helping her understand, by her losing weight, she not only reduces the chance of liver disease, also decreases the chance of cardiovascular disease, which is the #1 killer in our metabolic patients, as Anita pointed out. But they also reduce the risk of cancer and the overall longevity. So you can also not only prevent liver disease, but you also give them a means to have a longer, healthier life from a cardiovascular standpoint, cancer standpoint, and liver standpoint. So this is a patient you'll be seeing, all of you will be seeing these patients. Again, encourage for weight loss, encourage physical activity, encourage to work with a dietitian, and talk about reducing the risk in the long term when intervention is so important. And the primary care physicians and healthcare providers can make just a huge difference. Next slide. I'll skip over the next slide and we'll go to, I think, my last slide. I ended up on this again because I think this organization is so important. I just leave it on this slide just to remind you about the ALF. And I just want to thank Sydney, the ALF, and Lorraine, and everyone at the ALF, and just thank you for letting me be part of this. And also just reach out and say how profound respect I have for the American Liver Foundation, and also Project ECHO, which I think is really doing just great work for helping patients and people across this country. So thank you very much. And I'd love to answer questions with Anita if there are any, and just open up however Sydney would like us to proceed.
Thank you again so much for your presentation. It's so informational too. So if you have questions, please, unmute yourself. You can ask them or drop them in the chat. We did have one in the chat previously, and that was asking to see from Anita's presentation about the slide again with the workup/labs. If you're able to pull that up.
So while she puts this up, I want to compliment Anita and Sydney. I'd like to make a donation in Anita's honor. I think the ALF for that great presentation, and it's also to help relieve my conscience when I steal her slides and use them for my presentation.
All right, I can pull up what I have here. There we go. I think this is what was being requested.
Other questions? Or if you have questions
By the way,
about
I can say that is a great slide. And I have some of my primary care physicians do exactly that. Most primary care physicians don't do as thorough a job, but this is a great slide for everyone to use as a template when you're screening them for other liver diseases. I think the other thing that you have to add to that is, as Anita pointed out earlier, is make sure you take a thorough alcohol history, because that's also going to be in that. But those serological testings are markers for the liver disease are very helpful for us when we evaluate the patient. So that's a great request. And if you want to screenshot that, everyone, you should, because that's a pretty thorough number of tests that you need to do that we as hepatologists love having when we see the patients. Any other questions, Sydney?
I don't see any more questions in the chat. We'll just give people another second to think of anything. And if you want to switch over to our last slide too, about all of the remaining of the upcoming sessions, we still have 4 more sessions scheduled. So make sure to register for those. And again, all of our sessions will be recorded as we are today, and we're going to edit them and then put them on our YouTube channel. And the link will be sent out to you. Give us like a week or 2 to get them edited and posted. But again, here's the link to all of those sessions. We would love to have everyone here again. This is a great time. You have some experts here on the call and pick their minds and find out their information of everything that they know. Okay, well, I haven't seen anything come in with the chat, so thank you again to our presenters and Sydney for running things in the background, and of course, all of the participants. We love having you here. And if there's any way we can help you or your clinic, please reach out. We are here to help. Thank you so much.
Thank you, everyone. Great time.